friends. I'm Dr. Nirmal Frederick. I'll be the chief instructor for this course. So this program is on managing medical emergencies in ophthalmic practice. So we have a good panel of speakers. May I request Atik, Gagan and Jayanthan to join me in the podium. Slides not moving. Okay. It's my disclaimer. I have no financial interests. I'm associated with NABH and a few other organizations in a honorary capacity. So this is the program. So I've been involved in accreditation of eye hospital for the last 15 years. So over the last 15 years, when we visit eye centers for accreditation or assessment, many of the small eye care organizations are generally not prepared for these surprises. I think last session we heard about ophthalmic emergencies. So we are tuned to manage ophthalmic emergencies. But when surprises happen in the form of a medical emergencies, which can happen because most of our patients are vulnerable patients, extremes of age, have a lot of comorbidities, we are not able to handle that emergency, so crisis erupts. So what we generally see is non-functioning crash cart or expired medicine in the emergency tray, or they don't have access to ambulance, and many of the requirements are non-existent. And the team is less resource intensive or not trained properly to manage emergencies, medical emergencies. And they tend to panic a lot in front of the patients and their families. So that actually creates a crisis. And most of us don't have anesthetists during procedures. So if we have, so which is a requirement from a patient safety angle, it will be good for the surgeon, for the team and the practice image. So life is full of surprises. So we have to be ready and prepared to handle these surprises in our practice. And how do we go about that? So being prepared for medical emergency is not just about saving lives. It is about giving hope to those who need it the most. Because every second, the golden hour time, every second counts, every life matters, and every effort to be prepared can make a difference. So this instruction course is all about how to sensitize the eye hospitals and eye centers to be prepared on handling medical emergencies. So the first lesson is do not panic. So you have to be prepared because saving life is part of patient care. So it's not only saving the eye, so saving life is also part of patient care. So what we are going to discuss in the next 80 minutes is how to assess a patient plan for OP surgery and how to sense. So before that, how to sense and save a sinking patient. This is very, very important for preparation aspect. And try to answer all this WW about what we have to do, how we are going to do it, where we have to focus and why we should do this and when should we do this. And these are some of the key topics that are concerned with these medical emergencies. So one is having the right equipment and right training to the staff and how to communicate the bad news to the patients and their attenders and what are the common situations that we can encounter. So maybe we have a lot of time, so we can take questions from the audience. So I have a team of dynamic speakers and practitioners. Dr. Atik is ophthalmologist at Fatima Eye Clinic. So he will be talking to us about how to assess a patient plan for OP or daycare surgery. He is also the chairman ARC of Tamil Nadu Ophthalmic Association. And Dr. Gagan Dudeja is a principal assessor with NABH as well as consultant HOD of Orbit and Oculoplasty at Narayan Nethralaya. He'll be talking to us about the standards related to emergencies from the NABH perspective. Dr. Kumaran Murugesan runs the Kumaran Eye Specialty Clinic, ophthalmologist with keen interest in practice and infection control. He'll be talking to us about how he managed medical emergencies in his hospital. And Dr. Jayanthan, currently the editor of TNOA and eye surgeon at KSI Hospital, will be talking to us about training required for emergencies and code blueprint. So this is the program. Please stay with us. I know lunch is, we are standing between you and the lunch. Right. So this is important. So I'll be talking to you about what all emergencies that can happen, how to sense and save a sinking patient. So has few case stories that really happened. A 35-year-old lady has come for incision and curettage, and ophthalmic diagnosis was easy, just chalazion, and suggested a OP procedure. It's a daycare procedure, chalazion incision and curettage, and xylocaine test dose, because we are not sure about the allergic response to the patients. So this is what happened. So the next few minutes, he started itching and suffocating sensation. So when we assessed, patient was awake, oriented, but the voice was changing, and generalized flushing and breathing difficulties, and these were the vitals. So tachycardia, tachypnea, and the SpO2 was coming down. So how do we proceed? Can we make this as an interactive session? We can, some of you can answer, because these are common scenarios. Nothing related to ophthalmology. This is just related to being a medical practitioner. Right, so these are the hints to the diagnosis: acute onset, secondary to a trigger, that is the xylocaine injection. And patient had this sense of impending doom. She was very anxious, and the voice was changing, and she was panicking. So this is anaphylaxis, and these are the things that happens in anaphylaxis. So the tongue gets swollen, inability to swallow, and the eyes get swollen, and these are the ways in which patient can react. So we all know anaphylaxis is acute, potentially fatal multi-organ disease, and it involves prior sensitization to an allergen followed by a re-exposure. So generally we do ask allergy to eye medication, but we rarely ask about allergy to previous medication or any history of surgery under local anesthesia. So this is not the appropriate time to waste in doing investigation, because this is a clinical diagnosis. Unless you are aware of it, you may not realize that this is the problem. So investigations are not helpful in this acute setting. All you have to do is recognize that, and within minutes start a treatment. So you have to, there are a lot of symptoms, so potentially more than 40 symptoms. It's not easy to recognize, particularly when you are in ophthalmic field for a long time. So there's a lot of debate about local anesthesia test dose, whether mandatory or not. For as per risk assessment, it may be needed for some patients. There's no standard guideline as such, but standards do prescribe local anesthesia test dose if there is a doubtful allergy to. But allergy happens to not only to the drug, which is dose dependent, but also to the preservatives. Most of our drug companies use a lot of preservatives, so they can be allergic to the preservative, and there is a cross reaction among local anesthesia agents, whether sensorcaine or bupivacaine or whatever it is. So you have to do a thorough risk assessment and initiate steps in the management of anaphylaxis. So focus on acute management. So protect the airway. This is very important. So you need to have a small plastic airway which cost about 40 rupees. So this is very important device for these patients. And adrenaline injection. This costs hardly less than 10 rupees. You need to have them at least 5 injections in any hospitals where we are doing surgery under local anesthesia. Of course, you can add the injection hydrocortisone and injection Avil. All are very common life-saving drugs. We have been used to this in house urgency. You also need to monitor the cardiac status, position the patient comfortably so that doesn't harm the patients. So preferably with legs slightly elevated, and initiate transfer, because this patient would need support for a long time. So you have to treat give the first aid and then transfer to the hospital. So you can extend. So this is another real story that happened. A 55-year-old lady was waiting for cataract assessment. Dilatation took long time. She became restless after 10 minutes and went to the reception and said, "I'm not well." As usual, our receptionist asked them to wait without realizing the situation. And after that, this was the reaction from the patient. She was holding the chest discomfort, profusely sweating, upper body discomfort, shortness of breath, and in few minutes was more or less the classical symptoms of cardiac event. So we carved code blue. So our team is prepared for it. We've been trained for code blue activation and what to do during a CPR resuscitation. So it was activated and patient became non-responsive. Artificial respiration was given, oxygen given, CPR given, and code blue done, and then patient was transferred to a nearby hospital in a cardiac ambulance and admitted in ICU. This is another story which happened in a busy Saturday OPD. Patient was waiting for in the OPD, well-controlled diabetes mellitus, and luckily patient was known to us. We know the cardiac condition as well as the diabetic conditions. Patient became agitated and started verbal abuse. Again, sweating and tremors. So what do we do? So this is what happened in few minutes time. So these were some of the symptoms observed. And so this is quite a common emergency. So all we need to do is do a capillary blood glucose and if needed ECG, but CBG is more than enough. Check the vitals, blood sugars, and recognize that it is hypoglycemia. So most of the emergency drugs will have oral dextrose or IV dextrose. So give immediately the patient recovered, and then the patient was sent for physician opinion. Since the patient is a dialysis patient, she is used to the hypoglycemic situation, and the attender were also very helpful. So this is a 89-year-old male posted for cataract surgery with grade 4 NS. So most of the VIP patients and high complicated patients come with so many comorbidities. So we gave all types of local anesthesia, intracameral, peribulbar, but patient didn't respond, agitated. So how do we go about? So we have anesthesiologist all the time as standby. So he was really helpful. So he gave IV midazolam to the patient, not to the surgeon. Patient settled immediately. How I wish I had that. But so we continued with monitored anesthesia care, waited for 15 minutes for the patient to settle down, and then proceeded with the surgery. Post-op was uneventful and discharge. So just to debrief you about all these stories, can happen anytime to any practice. It does happen to small as well as medium and large practices. It can happen even the OP or OT or in the external areas. So these are some of the common emergencies in daycare centers. Hypoglycemia, anaphylaxis, asthma can get exacerbated, particularly if the patient is sitting in a closed room with AC. Seizures can happen, and impaired consciousness and cardiac arrest. So there are many ways of being sick and defining critical illness. We need to prepare our center, mainly our staff, to handle those emergencies. So we need to have intelligent people in the reception, not intelligent reception. So who can check the vitals? Ideal to have a trained staff nurse who can check the vitals and also monitor the patients on a regular basis. This is very, very important because most of these patients spend a lot of time in the OPD for waiting for dilatation or some other investigation. So CCTV might help, and they also should be trained to handle the vital signs and note the abnormal vital signs. That is more important. Knowing normal as well as knowing abnormal is important, and we also need to know our patients. So most of us are regular patients to us. We need to know their age as well as the comorbidities, and should have a gut feeling when we see the patients. And risk assessment we need to learn, not only having anesthetist there, but also the general profile of the risk assessment. Most of the anesthetists will flag a yellow sign or red sign when it goes beyond ASA 3 or 4 in eye centers, and definitely ASA 5 and 6 we need to take help of the general hospitals. So keep an eye on high risk patients. So elderly patients, multiple comorbidities, wheelchair, stretcher bound patients, and referred from other clinics because we don't know them. So they can give this. And you also need to assess your risk tolerance. So the risk to the surgeon is very, very important, and risk to the practice and financial risk. So particularly when you're taking VIPs or advocates and press people, you have to be very careful about this. So you have to take the history, red flags, and do a thorough assessment. Not only ophthalmic assessment, but also a general assessment is important. So reassess and communicate to the team. So let's see how our patients are there now. So the first patient's doing well, admitted in ICU, recovered in 6 hours. And so this was the status. The second patient took lifestyle modification and came back for cataract surgery after 6 months, treated medically. And both these patients went on to give wonderful review. So not only the patients were happy, the team was also happy. So nothing can replace training, teamwork, the skills and knowledge, but it has to be applied properly during this emergency measures. So that's more important. So we can't go away from risk, but we have to take risk. So otherwise, so the important benefit is the ability to save lives. So thank you so much for your kind attention. I request the next speaker to take over, and so if there are any questions, speaker to take over, and so if there are any questions.
What is your induction program in hospital, sir? Schedule like for new staffs, and do you have a protocol like every year, 6 months once, 1 year once, you do it regularly? And when you induct a staff, that is paramedics, I mean other than nursing staff?
No, every staff has to go through induction process. That is our system. So it depends on the critical nature of their work. If it is a OT staff, they have to be just observing for 15 days. So only then we assess their involvement, the skill and the knowledge, and then we slowly integrate them with the other staff. For non-critical staff like the reception or this, there is a process. So we test the skill recovered and then slowly induct them. So generally 15 days to 1 month is our induction time. And there is a review appraisal every 6 months. So if they need retraining based on the feedback with the managers or superiors, they are trained on that job.
Thank you, sir.
Yeah. So now I invite Dr. Atik to talk to us about how to assess a patient plan for daycare surgery.
For giving me this wonderful opportunity to be a part of your IC. So this is just a continuation of what sir has spoken. So surgical results alone don't give satisfaction to the patient. Like you do a cataract surgery, you feel thrilled, amazed, patient is 6'6", N6. That is actually not what the patient is looking for to be happy at the end of surgery. So a thorough analysis of the patient before surgery is vital for the patient to feel holistically good and to feel happy after surgery. At times, you need to take care of the attender more than the patient for the patient to be happy post-surgery. So to begin with, creating a rapport with the patient and the family, and to ensure that the anxiety level of the patient comes down before any procedure is very important. At times, it's a monotonous process where you see a patient for cataract, you go through the same story again and again and again. And when in a busy OP schedule, we may at times skip it. But it is not enough. For every patient need to be considered as a new patient, and we need to spend time with the patient. This helps in reducing morbidity during surgery and to avoid case cancellations and surgical delays. This is one of the most important prognostic factors for success in daycare surgery. Again, success, I don't mean by clinical success, overall success of the patient after surgery or satisfaction post-surgery. Another important, of course, we need to do this pre-surgery evaluation to safeguard us also. So who is fit for daycare surgery? There are certain clause and classifications. One which is usually followed is American Society of Anesthesiologists status. Grade 1 and grade 2, they are considered as fit for daycare surgery. Grade 1 is a normal patient without any comorbids. Grade 2, say for example, a diabetic or a hypertensive under good control comes under grade 2. Grade 3 is patient with next level disease. Grade 4 goes to diseases like maybe nephropathy or neuropathy, patients like that who are having severe systemic diseases. So who's fit for daycare surgery? Just age is definitely not a criteria to say fitness. We are seeing 80-year-old, 70-year-old marathon runners and people having MI at 40 years of age. So age is no longer considered as a criteria for daycare surgery. BMI of less than 40, as long as comorbids are well controlled, is a very good prognostic factor. Even 40 to 50 is a gray zone where we are not very sure about it. It has to be considered on a specific case-to-case basis. Patients with BMI more than 50, of course, are with higher risk of getting peri and post-operative complications. So thorough examination of the patient is essential, and each patient should be considered on a case-to-case basis. To begin with history, spend some time, and a detailed history needs to be taken from the patient. Comorbids, diabetes, hypertension, COPD, of course, off late we are seeing a lot of lung-related issues due to the past 3 years of mess all of us went through. Seizure disorder, CVA, thyroid disorder history to be taken. Off late, anesthetists are more fond of this concept called as effort tolerance. They call it METs 1 to 8. So what they mean by effort tolerance is, in some places we find the anesthetist in a second floor or first floor. And if a patient is able to comfortably climb 2 floors of stairs, come to the anesthetist and sit and talk, they call it as effort tolerance being good. That is METs more than 4. So that is enough for that is a very important prognostic factor they feel to assess for a patient who is fit for daycare surgery. METs above 4 is amazing, but METs 4 minimum is needed. So a person who is able to complete 2 stairs, a 2 staircase climbing is considered to be reasonably good for daycare surgery. Medication history should be taken, previous hospitalization history, anaphylaxis history, as sir pointed out, is something that is extremely important. Allergy history is very important, that needs to be taken during our history. Medication history, this again is a big gray area. When to stop blood thinners? Of course, when we do cataract surgery, many feel this is clear corneal surgery. We don't incise the sclera, there is no bleeding encountered. But unfortunately, it is in those cases where we end up with the iridodialysis, lot of bleeding, and then we cut a sorry figure to the patient post-surgery. So always safer to stop blood thinners. If it is warfarin, at least 5 days is needed. No point in stopping it 24 hours or 48 hours prior to surgery. If we are not sure about it, we can talk to the cardiologist, get an opinion, find out how long that specific blood thinner can be stopped. When to resume? Again, if there is low risk of bleeding, it can be started the very next day. Certain procedures like maybe oculoplastic procedures or any iris repair or a retinal surgery done when we are expecting bleeding to happen, it's always safer to start 2 to 3 days post-surgery. General examination, detailed general examination is very important. Airway examination is mandatory for all patients because in case of any medical emergency, that needs to be assessed. And hydration status, pallor, clubbing, cyanosis, and pedal edema should be examined. And history and examination, if the patient will be able to lie down, also should be taken because most of our surgeries require patient to lie down flat for at least 10 to 15 minutes. Systemic examination, a complete cardiovascular, respiratory, abdominal examination, including genitalia and CNS examination needs to be done. This is something very important. For all surgeries, at least a basic blood workup is mandate, which will help us to save our skins in case there is a medico-legal issue or any emergency post-surgery. A basic hemoglobin, total count, differential count, sugars, urea creatinine and ECG is mandate for all patients, whatever be the surgery that is done. And in case the patient has any issues, chest x-ray, echo, coagulation profile, in case we are expecting bleeding during surgery, and serology for our safety and our staff safety is very important. How expensive are these tests? Most of our surgeries we charge 25,000-30,000 and above, and these basic tests with the nominal profit margin will hardly cost us 1,500 to 1,600. So this the patient will be willing, provided we are able to talk to the patient and tell them that this is for their benefit and not for us. They will be more than willing to spend it. Expert opinion is always essential. A good examination by a cardiologist, pulmonologist, endocrine, or an anesthesiologist on a case-to-case basis is needed. Separate consent for anesthesia and surgical consent should be taken. This again is mandatory. This is something which we follow in our place. Any physician coming, this form is given, a quick checklist for them, and they're required to fill this details and say whether the patient has any risk factors, moderate risk, mild risk, or how the surgery can be done or planned for the patient. Normally, there's a slight aversion between anesthetist and any surgeon. We feel they are our enemies, but unfortunately they are not. They're only trying to save us and help us give good results to the patient. Fear of losing our patient to our neighbor in case we suggest these tests or tell them to get a physician evaluation done is a myth. It is not ideal to just take up a patient and go ahead with surgery and try to do these assessments by ourselves. It is always safer to be a king in ophthalmology and live life king's life rather than be a jack in anesthesiology and then become a laughing stock in case an issue arises. So let us stick what we know best. Physicians and anesthetists are only our saviors for us and our patients and not our enemies. Thank you so much. Thank you, sir, for this wonderful opportunity.
My job is very easy because of Dr. Nirmal and Atik. Whatever they have told, we'll try to correlate in this, right? So we have had some key points in what they have told. They have emphasized those points while handling those emergency patients. Now let's see how that disclosure. NABH has got different chapters and different chapters will have different things. So we'll not go into those details, but this is the first chapter of NABH where it starts. So that's why this slide is here. So the first standard of NABH and the first chapter talks about requirement of emergency room or department. If it's a hospital, it's a department. If it's a clinic, there has to be an emergency room. So in short, you have to have a place where you can handle those patients. We're talking about checking blood sugar. We're talking about, an ECG, giving oxygen, maintaining airways. All those examples what you saw. Where are you going to do that? Are you able to do that in your chamber? No. Where do you keep? And wherever you are going to maintain that, there has to be a bed, probably an oxygen supply, and all those things. So that's an area, you can call it as a room or the emergency area, which is a mandatory requirement in NABH standard as well as it's a legal requirement, which will come further. And we have sufficient examples there to make us sure that, we need to use it. At least in our hospital, if it's big, we are using it every day. And that emergency area also is not only for your patients, it would be for patients who are coming to your facility, right? It could be even the attenders of patient. So not only the patients themselves, anyone who would be in your facility and in and around would be required. And what should be the size, scope and all depends upon your practice and where you are. Other important thing was, Dr. Nirmal touched upon the second patient. They had to shift that patient to ICU after giving a basic life support, right? So you have to have a process of transfer of an emergency patient. And it's not a verbal process because when that thing happens, frankly speaking, even our staff is not able to react because it's something new for them. So it's a situation where we need to be prepared. You need to define beforehand. The training has been shown that what is the process of transfer? How are you going to transfer that patient? Where are you going to transfer that patient? Which hospital? Right. So all those things are a requirement which you need to put in place. I'm not going into detail because of paucity of time, but these are what standards also ask you to have. And other thing would be the transfer process. We are talking about patients going outside our organization, but we also get patient in our organization. So I will have a child coming from NICU for, let's say, ROP screening and laser in our hospital. We'll be doing some pediatric surgery, shifting the patient, adult patient going to medical ICU, coming from ICU for certain procedures. So you also have to have, if your practice is sizable side or if you're in a multi-specialty hospital or a big ophthalmic setup, we have to also receive patients and then, transfer them back. So all these things have to be documented. That's a requirement. It's not that we told patient to go to a hospital. What condition patient had gone? What are the brief things? Who is going to transfer? How are we going to transfer? So that mechanism has to be there and periodically revised so that we remember how we are going to do that. Other thing is, how are you going to see your emergency patient? So if you get an ocular emergency, which was previous session, or you get a patient. So we also spoke about an intelligent receptionist. So how are you going to assess? Is a nurse is going to assess a PG, a fellow, or a doctor? So we should have some parameters of assessment of patient, which includes basic vital parameters and let's say a brief history. And we can have this as a standardized thing that, okay, this will be an initial assessment of ocular bar, ophthalmic emergency, ophthalmic bar, a general emergency, and that has to be done. We also need to define time for that. It should not be there that in our hospital, when a patient is sitting with an emergency, no one is responding. So there has to be a golden hour, a golden minutes where you respond. So put in place that are we responding in time to a patient who's in emergency. If it's your single man practice, you are the boss. You will put things in place. But the moment it goes beyond one, you need to put protocols in place. And also monitor the compliance to these things. Also in NABH, we also talk about seamless care because the patient is not under one particular person. You are moving from department to department. So patient would come probably, with some injury and then, from let's say it goes to cornea because it's a case of chemical injury now. So it would have been seen by someone, but then it gets transferred to, let's say, cornea care. But at any given point in hospital, cornea patient goes to, let's say, something else. But one particular consultant or one particular department is taking care of the patient, and that's how we pass patient from one department to other, or the care is given from one clinician to the other, right? And we also need to have a shift system. If you are having admissions, so nursing staff, they give handover. Same thing happens to these emergency patients. So if you're having emergency patient in hospital, there has to be a handover to another clinician, another duty doctor, or whatever. So those things have to be. It's not only that the nursing staff hands over, you also have to clinically hand over the patient to whosoever is going to be taking care next. So other thing would be, we discussed that, why we should not have. One thing would be MLC. It's a myth that, okay, we write that patient doesn't want an MLC or something. I can in fact tell, we had a patient of, just now in Bangalore, a patient has come with an emergency attended by some person. And, within 3 days, police people have come and asked why you have not sent police intimation for this case. So it is very common. So you have to be there, and the burden of MLC is on clinicians. So wherever you are suspecting foul play, the burden comes on to you to maintain proper document, which is your MLC record, and also police intimation if you feel is required for that. And you may just have this opportunity once in a year if it's a small practice or you have a niche practice, or it would be on a daily basis or multiple MLCs in a day for us. So we would have typically 3 to 10 in a day. So the important thing again would be differentiation between ophthalmic emergencies and general emergency. So that would be our first point, because we have to see it's ophthalmic emergency, entirely our domain, all of us are trained. The moment it goes for a general emergency or a polytrauma, let's say ophthalmic plus thing, you need to go into triage. Put your triage policy in place. What I would feel is that you have to have ophthalmic, non-ophthalmic, ophthalmic emergencies, ABC triage, and let it be in the emergency area which you would have made, so that it's a ready reckoner there where it goes, and accordingly we progress. So triaging is an important function, and we want to have a triage policy and document in your place for NABH. And ambulance service is definitely required when you're shifting patient. It may be your own ambulance, or you could have a contract, or it could be something which works in your city, but we need to have a proper ambulance. And remember, sir told a cardiac ambulance, a facility where you could transfer a cardiac patient. All ambulances are not same. So have an ambulance which has got required required things and is registered proper. Make arrangement for that. We never know when we need it. And resuscitation, we discussed about training. Atik touched upon that part. So the entire hospital is trained for at least basic life support, so you are able to handle code blue. We discussed about coding, and that thing is much in detail for NABH. The trainings and all the photograph what you saw are mandatory trainings. They have to be done, they have to be documented, and after training we have to also evaluate whether the staff is up to date or not. Otherwise there's a reinforcement of training for that. It's not training done in this hall and gone. So there has to be a evaluation after that. And whenever we do a CPR in hospital or code blue, we record all the events down. And there's a hospital in Bangalore, it will be probably discussed multiple times in session. They had this event, they shifted a patient, but ultimately whenever the investigation was done for that particular hospital, this record of CPR was the one which was taken into account, and hospital was actually told that there's nothing wrong with what you have done. They had a CCTV in OT, they had captured the entire CPR and everything being done, and also they had recorded, which was very helpful to them. This is some years back. Okay. And other thing would be, So other thing is for emergency also you need to have a handling in place in terms of operating upon them, having a consent, and documenting everything. Give me 1 minute, just so that would be there. Other thing is how are you going to do the monitoring of patients. So we also had that example that during surgery, during procedure, we're talking about MAC or anything. If you're operating under GA or sedation or even MACs, you need to monitor the patient during the surgery, which was emphasized in example, and even after the surgery before you discharge them. So need to put that protocol in place. And in handling those emergencies, we're talking about use of adrenaline. We're talking about use of other medications. How do we get? So as part of medication management in a hospital, you need to have emergency drug list, emergency drugs stored in places where it is required. And there has to be a count of that. So emergency drugs are counted every day. It's not like at night duty, we used to pilfer drugs from emergency government and next day the sister will replace. So here we are not having that luxury. So if I have to keep 5 vials of adrenaline, that record is checked every day by the sister that there are 5 vials. If it has used, it has to be replenished. If expired, it has to be changed. So management of emergency medication list and everything is one important thing. And for consent, many a times in emergency, the patient may not be in a condition to give consent, or you're operating on a patient like, you have emergency need consent. So have that thing in place, how your hospital is going to handle that surrogate consent, how you're going to take consent in those emergency conditions. And this will be the last slide. We also, if you have an emergency, we have to look at emergency as a separate area for infection control, not applicable to most of us, but a big hospital, a big emergency area. Those are the standards which also focus to have infection control practices and monitoring in an emergency department or area. Thank you for your kind attention.
Thank you, Gagan, for highlighting all those standards. Do we really need a separate emergency room?
Sir, I would say
in ophthalmic setups. So can we combine, because
I mentioned that it should be an area where we know that, okay, if a patient has an emergency, this is a place we are going to use. So if we can designate like a particular area, which can be also used for other purpose, but we should have a go-to place where everyone responds. So that would be, otherwise we don't know where to go. And if we call for help, they don't know where they should go. So if you have a dedicated area, everyone knows that in emergency, patient goes there. Anyone who's supposed to come for help goes there. It's really, and rest of the time can be used for anything.
Okay. Just to add, I think we need to have signages because patient have to know. It's not that our staff or team has to know. Patient has to know that there is a place for emergency and ensure that proper equipments are there in that area. So that's what we are looking for, not exactly a excluded space. Right. So since we are talking about equipment, thank you, Gagan. Thanks for highlighting all those standards. So there are a lot of equipments needed to manage medical emergencies. To highlight those, I request Dr. Jayantan to talk to us about the equipment needed for managing medical emergencies, as well as how to train the staff on those aspects.
So, thank you, sir. Thank you for this wonderful opportunity. So, I'll be having two talks. First, I'll be talking about the Code Blue equipments that is required, and then I'll switch over to the training part. So, Code Blue means that someone is experiencing a life-threatening medical emergency. Usually, this means a cardiac arrest or a respiratory arrest. So, coming to the equipment, the best emergency kit is one that has been prepared and maintained by the doctors based on his or her own needs and is easily accessible for the immediate use. So how to go about? Create an infrastructure for provision of emergency care to your patient, gather the information, document the Code Blue, and then the final thing is to practice the way your clinic is going to with that when you have an emergency. So the basic components are, first you need to recognize, start on with the CPR, go ahead with the compression, airway maintenance, and the defibrillation. So the equipments that is required will be dealing along side by side with this. So the one equipment that you really need to have is the crash cart, which is also known as the emergency cart, the emergency response cart, the code cart, or an emergency trolley. It is a multi-drawer wheeled cabinet with an essential medication and tools that are required in the emergency situation. So the purpose of this cart is to provide immediate access to the supplies and medication, facilitate coordination of the emergency equipment all at one part, and to save a valuable time at the time of emergency. The crash cart will vary from hospital to hospital depending on the individual facility that is available and the patient population that they are going to cater. The best practice is to keep supplies that are frequently used together in the same drawer and separate your drawer based on the function. We'll see that in a while. And make sure every drawer is clearly labeled outside. Okay, so coming to the components, it has the external and the internal parts. The external has the oxygen supply, the defibrillator with the monitor, suction apparatus, stethoscope, the checklist and the drug information sheet, and the other things comes as the internal ones. So remember, literally and figuratively, the bigger things are often the equipment that you are going to utilize first, and you want to be able to keep them handy. So keep them outside. The first of it is a portable defibrillator or monitor. You can make a quick decision on how to proceed with the code when you are able to assess your patient's cardiac rhythm and the respiratory status. So if you want to determine that your patient is in a legal cardiac rhythm, you'll be able to go, you'll be ready to go. Make certain to have a pediatric pads as well. Some may say that we are not going to cater for the pediatric population, but as some of the speakers said, there will be an attender, a pediatric patient who walks in and who can have an issue. Right. So the automated external defibrillator, this is the best one to do because it automatically reads and analyzes the rhythm and prompts if the shocking is needed. So basically, we are not good enough in assessing a ECG, and if you are not going it on a regular, we'll be forgetting it. So, but this machine will do it for you. So all you need to do is activate the AED, apply the pads. This AED will analyze the heart rhythm, and when it prompts, just press the shock and it will deliver the fibrillation. So if you don't have an access to an AED, you can have a manual defibrillator. So as I said, when you have a manual defibrillator, you should be very good in actually assessing the rhythm of the patient. You need to be able to read the ECG. So next is a portable suction machine. This will allow you to clearly assess your patient's airway and also to prepare for a possible intubation if the patient requires. So it allows to clear the airway quickly and prepare for the possible intubation. It can prevent the pulmonary aspiration as well. The last one is the oxygen tank. Once the airway is patterned, you can crank open your oxygen tank and deliver the oxygen by appropriate measures. So coming to the oxygen cylinder, you need to have a type B cylinder. The important components include the cylinder, the key. The most important of all this is the cylinder key, because when you have an emergency, that when you will be searching for the key, and if it is not found, you are going to be in trouble. The cylinder trolley, pressure gauge, pressure reducing valve, flow meter, and the outlet to connect the oxygen tube. Right. So the mask used to the CPR. You can have a pocket mask or a CPR mask, which is used to safely deliver the rescue breath during a cardiac arrest or respiratory arrest. This is a one-way protection valve which allows gas to pass from the rescuer to the patient without any physical contact between the two. And if that is not very convenient, you can go for a bag valve mask resuscitator. It's a handheld device commonly used to provide a positive pressure ventilation to patients who are not breathing or not breathing adequately. So this helps in administering high flow of oxygen. It provides a provision for the positive end respiratory pressure, provision for controlled ventilation, and augmentation of spontaneous ventilation. Right, that oxygen from the cylinder could be transferred to the patient by means of a simple oxygen nasal cannula, but it provides only a low flow of oxygen, consistent low flow of oxygen. So if you want to gauge it, you can go for a simple oxygen mask or a Venturi mask. The preferred one would be a Venturi mask. Each color represent a amount of flow that can be given to the patient. Right. So coming to the draws, you can actually have a general guideline on how to stock it. The first draw could be the medication, because apart from the other bigger equipments, the next one which you are going to deal with is the medication. And with the help of your anesthetist, you can actually prepare a list and then stock your medications. Next would be the IV solutions. The other one with the adult intubation, the blood draw supplies and the IV supplies. Finally, the tubings, and the miscellaneous comes at the last. So the most required will come at the first draw, and the miscellaneous will come to the last draw. Okay, as I mentioned, you need to have a pediatric resuscitation kit also. So the best part is have a knowledge of the content and then create your own crash cart. The most important of this is, during a code, knowing where your supplies are located on your crash cart is as important as having everything necessary. So navigating your way through a hectic code is much easier when you have an organized system. So always, when you prepare your crash cart, always prepare a code for that also. And then keeping your supplies inventoried and inspected is very important. Maintaining an inventory of your supplies and inspecting them on a regular basis is very crucial. Remember, you don't want to be in an emergency and find that your cart is missing an appropriate size endotracheal tube or that your epinephrine is expired. Right. So this is a miniature version of the crash cart. So the main advantage is that it has most of the supplies of a crash cart, but it is very easy to carry to a remote place where you have an emergency. You can actually carry it, and you can carry this in your transfer vehicles also. Thank you.
So the next person.
Yes, sir.
Yeah.
So it's a next.
Sorry? You're not. Yeah, taking consent in the emergency situation. Yeah, in emergency situation, it is just implied consent. So if there is an attender, you can inform them, take oral consent, and try to do the first aid and emergency. For transfer, it's always possible to get to a attender or talk to the nearby person, inform about the transfer. So that is more important, right? And then while giving discharge summary, hand it over, or case summary of that patient, hand it over to a whoever attender is nearby and get the signature from them. So that acts as a consent as well. No, in emergency situations, courts may not ask you. What is more important is the care process given to the patient and the first aid given, and what is the standard of care. That is, yeah. So whatever you do, document it. That's more important.
Thank you, sir. So the next one would be the training required for an emergency and the code blue drill for the staffs. So as I already mentioned, code blue is one of the emergency procedure codes for an cardiopulmonary assets and life-threatening emergencies in any area of your hospital. It's a term used to alert the code blue team to an area where a person has a cardiac or an arrest. So any attempt at the resuscitation is always better than no attempt. The use of code is initiated to convey essential information quickly with a minimum of misunderstanding to the hospital staff while preventing a stress or a panic among the visitors of the hospital. A code blue will be initiated on all, as I said, could be a patient, could be a visitor, or at times could be your own staff suffering a cardiac or a respiratory arrest, showing the following symptoms of not responsive, no breathing, and no neck pulse. Right. The first thing what you need to do is have a good, effective code blue team. So, and code blue ideally has a first responder who identifies and then calls for the code blue. The second responder who comes and starts the procedure, the team leader, airway manager, medication nurse, recorder, IV nurse, security, or a hospital. So, is this how every hospital has to? No. So, there are over 1 million of different combination of code blue team depending on your hospital size, the staff structure, everything. So, you can actually take your own decision of setting up the team. So as I said, the first responder will be the first person to assess the patient's responsiveness and then call for the help. So you need to assign the role for every of your team member. So the airway breathing monitor, the defibrillator role, the medication nurse, the recorder, who's very important when everything is happening. One person has to record, the primary nurse, and the most important of all would be the code blue team leader. This role is assigned to the most competent ACLS provider available. A physician from the anesthesia or emergency medicine or internal medicine are charged in the team. If they are not available in our ophthalmic setup, we need to take up this role. A rapid response team leader or a physician is responsible for directing the resuscitation effort, and he will be running the code throughout the procedure. So an effective leadership is one who designates a role to team members and directs their action, dedicates appropriate treatment as per the ACLS guidelines and gives order to the team member, decides appropriate disposition of patient once the patient is stabilized. Before the patient attender, brief the patient's attender after resuscitation, make sure that the information has been passed to the patient's family members, ensures that one member is designated to record the event in the code blue team. So as we said, like talking to the patient's attender once everything is fine and recording everything is also a role done by the leader team. Okay, so a rapid code team assembly is very important, which leads to high quality CPR, effective code leadership, and this will lead to an improved patient outcome. So the effective code blue is developed by means of effective training. Make sure every team member is being trained in BLS and ACLS. The initial and annual individual team role training is also important for every hospital, and the personal training of the leader is the most important of all this. So who need to take a BLS and ACLS? A basic life support is intended to be for anyone who needs to know the basic principle of CPR, AED use, other primary model. So every staff of your hospital should be trained in a BLS, and the physician who's in charge or the doctor who's going to take up the lead role should have an ACLS training. So first decide, are you going to learn and teach your staffs, or are you going to seek an external agency's help in training? It's always better to go for an external agency. When you are going for an external agency, there are a lot of AHA associated centers which can give you the BLS or ACLS training. So it could be a blended model or a classroom training, whereas in a blended model, you have all the online materials which is available. You can go through the theory, read, and then go to the center and then get your own. Basically, it actually saves your time. Or you can have a complete classroom training, and end of the procedure you will be given a certificate which will be valid for 2 years. The BLS deals with the basic CPR and other cardiopulmonary emergencies like the stroke and cardiac arrest. ACLS basically is an advanced cardiac emergency handling procedure. So the IV therapy and the knowledge of ECG is all being taught in the BCLS ACLS courses. This is very, very important, and at the end of the training procedure you can create a protocol for your own hospital. So you'll be given a certificate which is valid for 2 years. You can make the protocol, laminate it, and paste it in your hospital. Right. So as I said, the leadership has to be effective. So getting a leadership training is also very important for us, especially in a setting like an ophthalmology where you don't have anesthetists running around all the time. So you need to be ready to take charge. Your roles and responsibilities and the responsibilities given to the staff should be regularly monitored. Ability to coordinate activities of the members is very important. You need to have a shared mental model. Good assertive communication is very, very important for a leader. So remember, in a communication, the message only communicated if it is both sent and received. Always remember, whatever meant is not said. Whatever said is not heard. Whatever heard is not understood. Whatever understood is not done. So only when a thing which you are telling is getting done, it means the communication is complete. So for that communication, we have lot of training modules which is required for the leader. Right. So we got the best of BCLS, ACLS. We got a good team. Is that all enough? No. If a CPR is performed infrequently, the knowledge and skills are lost within weeks of training. And there are a number of studies which have said an in-situ training program every 3 months decreases the median time of a chest compression from 33 seconds to 13 seconds, and defibrillation time from 156 seconds to 109 seconds. So the regular scheduled mock codes is all that is required. So of course, the practice makes us perfect. Right. So the objective of having a mock trial is that you need to discuss the value of performing a mock trial to your staff, make them understand, and then do it on a regular basis. Discuss the importance of delineating the team roles. For example, you must have trained within a month. If the staff moves out, you need to bring a new member into the team and then train them, and the coordination among the members should be good. So that's one reason why you need to have a mock drill. Right. Have a BLS mannequin. And have a protocol for doing the mock drills also. It could be once in a month, or it could be a fortnight also. If you have a day and night shift, you need to have a mock drill both in the day and night shift separately. Announce that as a real code. You can start it as a low fidelity. Low fidelity is like having 1 or 2 members, especially in a night shift, to help them. Or you can move on to a high fidelity where you can have a simulation, full automated simulation mannequin, and then go ahead with it. Both adult and pediatric scenarios has to be created and then done. Finally, all this is done and the briefing has to be done. In a briefing, you need to ask 3 main questions. What went well? What could the team do differently next time? Any safety or an equipment concerns that has happened. Right. For this, you need to have certain evaluation metrics based on the performance, the clinical, or the equipment, or the soft skill. Anything. You need to have evaluation metrics, and the evaluation metrics has to be evaluated, and then the mock drill has to be completed. So mistakes are okay in a mock drill as long as it helps the staff to do better in the real life scenario. So participating in mock drills on a regular basis is a proven way to boost your performance. Mock drills train the staff to be able to react efficiently in a life-threatening situation when every seconds is counted. Ultimately, practice makes perfect, and performing regular simulations in a controlled environment can be beneficial for the staff and lead to improved patient outcomes. Thank you.
So, thank you, Jayantan. You covered the requirements for equipment as well as calling up load blows. Very, very important that we train all the staff. So ideal is to train all the staff, or at least the basic and ALS support for the staff working in the theater. So that would be a useful teamwork. We go on to the next talk by Dr. Kumaran. He'll be talking to us about a few cases he managed in his eye center. So a few case studies. Over to you, Dr. Kumaran.
Good afternoon and a warm welcome to one and all. When you face an emergency, but as you know, there's always some teething problems when you face an emergency. Things don't go the right way as you have planned it on your paper. So we as a field in ophthalmology do deal with significant number of geriatric patients, but we have difficulty in dealing with these patients because emergencies, we don't see them regularly. Most of the eye care centers in India are still run by a single or a couple of doctors. As we are not dealing with emergencies, it becomes difficult for us, and we do not tell the difficulties our staffs are going to face. So it's very important to have a dedicated code blue team in your hospital, however small or big they may be. So I'm now into my 17th or 18th year of my practice. The first 7 years, I didn't have a code blue team, and I was very lucky that I didn't have to face any situation. But once I formed the code blue team, an emergency situation happened, and I'm going to share to you my story of what I did and how you can learn from my mistakes I went about. So this was way back in 2017. We had a 64-year-old lady posted for the second eye surgery, reported to the hospital reception. She was shifted to the OT after initial assessment, all vitals normal. And at 10:30 a.m., she wanted to use the restroom. She came out. After that, she fainted outside the OT complex, became breathless and collapsed. I was not in the scene because I was operating on another patient. So the code blue was activated and the patient was shifted into the OT. So we really didn't know what went wrong. We have done all the investigation for the first eye surgery. Everything was normal, but we really didn't know what to do. So we did a retrospective analysis to see what happened. This lady had actually walked in one evening in a busy OPD. She presented to us from the nearby 30-40 kilometers from Chennai. She underwent all the investigation. She was found to have a bilateral cataract. All necessary ocular and systemic investigations were done. We do have the histology test, and because everything was normal, I did look into her medications, and anti-diabetic, everything was normal. She went underwent for surgery. She was for the findings, everything was normal, and we fixed her second eye surgery. So what really went wrong? So on the day, she was shifted to the OT. Auscultation showed rales and bronchi. Her BP was sky high, and oxygen saturation dropped. She was started on Lasix and nitroglycerin. And we did have an MOU with a nearby hospital. So with minimum delay, the ambulance arrived. And with the theater notes from the anesthetist, I was not able to accompany because I was already doing a surgery. One of our stars accompanied the patient. The patient was received in the ICU nearby. It's very important to have an MOU because sometimes you will not have beds in the nearby MCU hospital. Artery ventilation started, everything went on well, but suddenly at 12:45, she had a ventricular rupture and we had to lose the patient. So what really went wrong with us? This patient was an obese patient. I had actually looked into a medication, but did not look into a prescription. This particular lady had actually skipped 2 of the medications which a doctor has prescribed. The son came up with the prescription later. The ECG, serology, and blood tests were normal. We got carried away, and the first eye surgery was uneventful. So when we admitted the patient after 7 days, we did not re-evaluate her, which is very important whenever you do a surgery for high-risk people. So we had difficulty in deciding on what was the problem because we didn't have any history. She was an obese patient. She had difficulty in finding an IV line because we don't start IV lines for all our patients, and very difficult to say who is high risk or not. And there was panic all around. The first time we are facing a code blue situation. The other thing is that we didn't have adequate staff to shift this obese patient into the stretcher. That is very, very important. So unfortunately, the CCTV camera was not functioning. We don't know why it didn't function. We had not recorded the events. The only fortunate thing was everything happened in front of the son. So he was actually seeing what we were doing, and that was the only console which could have, which saved us from other legal situation. Imagine if this has happened inside the theater where the staff and the other people are not allowed, it could have been really difficult. So how do you prevent all this? Have a high degree of suspicion, follow protocols for readmission, have an IV line for all high-risk patients, Check all your emergency medicines, gases, and instruments before you start your OT. Have a dedicated person not only check your ophthalmic instruments, make sure all your emergency equipments are in place, assign a staff separately for this, and have an emergency for minimum 6 people. So finally, have another physician or at least an anesthetist to monitor your patient so that you can perform your surgery well while he does this. So these are the other common emergencies we come across. Hypoglycemia is a very common setting which Dr. Nirmal has clearly described to you about. And seizures is something we have not discussed previously. The main aim of seizure is to protect our patients from trauma, prevent aspiration, and prevent further seizures. This is something we come across in ophthalmic practice quite common, the vasovagal syncope. Some of the reasons are severe anxiety, fear, stress, and acute anaphylactic reaction can also precipitate a vasovagal attack. The major pathophysiology is sudden parasympathetic response or any action which is going to decrease the sympathetic activity or any factor that reduces the venous return to the heart. So how can you prevent a vasovagal attack? Always have an awareness, a careful history taking, preoperative evaluation, ask the patient about the head tilt test because some patients do complain of syncopal attacks previously. Intraoperatively, especially during squint surgeries, make sure you manipulate your ocular tissues very gently and have a support staff or a standby anesthetist whenever it is needed. The main treatments are CPR, intravenous epinephrine, rapid rehydration with NS, and the Trendelenburg position. So in summary, have a code blue team with minimum 6 persons. Remember to record the events. Ensure all your emergency medications and medicines are in place. Checklist them on a daily basis. Please have an MOU with a BLS or ALS ambulance and with the ICU providing hospital, multi-specialty is nearby. A standby anesthetist or a physician for all high-risk cases. And as Dr. Jayanthan has said, frequent training, mock drills. Finally, have everything in place and pray to the Almighty that nothing eventful happens. Thank you.
So we covered quite a few topics related to this. So last is kind of crisis and emergency situation, not to the patient, but to the practice and the doctor. So how do we handle this? I think we have to be prepared for that also, because it recently had 2 extreme incidents, very shocking, brutal incidents. It should not come to us, but we have to be prepared. So that's all about crisis management. Be prepared and stay connected. Right. So we talked about golden hour in MI, and we all know golden hour in RTA. And this is golden hour in attack on hospital or any crisis. Not necessarily the attacks we see in the social media or TVs. So it can be subtle form of attack. Somebody, a group threatening a physician or a staff. So it actually starts in a small scale, and due to some elements, it escalates into a crisis situation. So this is a pressure cooker situation. It can burst, it can settle down with few whistles, right? So basically, these are the inciting causes. So the doctor generally is in a state of shock. We can handle any human ophthalmic emergency. But general emergency or these kind of situations, most of us in the shock. And particularly when it escalates to press or social media or police, and versus the political splinter groups and agitation. So all this becomes a pressure cooker situation. This was our state few years back, but now the roles are reversed. So we are blamed for every disaster, and attacks can happen, and attack not only on the staff, on the equipment or on the premises, but also on the reputation. This attack on reputation is ongoing. So it's actually increased in the last few years with the advent of social media and Google review, Facebook, Insta, all those things. Even our stakeholders like insurance companies, the aggregators have taken this route to slander us. So basically, crisis and emergency situation may be structure induced, right? Infrastructure difficulties, process induced, staff spilling something, and doctor induced, drug induced like anaphylaxis, self inflicted can happen, right? Handling a mentally disturbed patients, or a mob violence like patient or family. So this is, yeah. So most of us, we don't realize our strength, weakness. So generally, when we don't have the infrastructure to meet the patient requirement, we should not take over and above our capacity. So never take patients beyond the scope of our specialty, and ensure equipment, drugs are available, and errors of counseling or communication. Generally, our staff tend to paint a rosy picture. They always give 99.9% or 100% no errors like that, or over promise. So this is where we get into problem, and not following the consent process. So it's always important we document all those things. Staff induced, generally they will act in front of us, but they may not be complying the instructions. So wrong site, wrong route, wrong drug, wrong eye, all this have happened. It will continue to happen if we don't monitor the situation. And rough handling of patient and relatives. So most of our patient relatives, particularly the new age attenders, are very touchy and finicky. They have a huge ego when they come to a hospital. So they want to record everything. So they are very suspicious and a bit biased. And any wrong news, that's exaggerated, right? And somebody working in the theater or any area where this emergency happened, if they come over, they can spill the beans. And complications, I think we have discussed enough. I will not go into the details. And so basically, we have to face the crisis as well as prevent the crisis. This is more important. Preventing the crisis from escalating is very important in crisis management. Avert the crisis, right? So there is a huge gap between our perception of running a practice and the way the staff do. So we have, and as well as the patient expectations. So we have to bridge the gap. So ensure these 4 P's are important. So we have to handle these 4 P diligently. Police, press, politicians, and public, right? So when they need us, they will shower flower petals, but when they don't need us, they can extract in many ways. So the first one is liaison with the police. If there is a death in the hospital or a crisis in the hospital, the general demand is arrest the doctor. So basically section 304A. So generally what happens is we have to handle this with the help of our associations or a group of doctors. So talking to the higher authorities really helps. So in many incidents, we have talked to the superintendent of police or the higher ups like the ADGP or DGP and averted the crisis. So instead of dealing with the local police, always escalate to the higher level. And liaising with the press, particularly on table death or any other crisis, it's always better the owner or the staff or doctor is directly not involved with the press. So ensure you work with IMA or any other even ophthalmic association, and ask the office bearers to brief the press. So that will clear the doubt. And generally press reacts favorably when the top doctors are involved. So their ego is also a bit brushed up. So when the top brass come to them and talk to them, most of them it is settled. And this is the most difficult group, particularly it's basically a splintered political group. The large groups have their own TV, media, all those support system. And when they get involved, police are reluctant to take any action. So a general rule is talk to the top brass as well as call to the political group, call them to a room, talk to them in a separate room. So highlight the situation that this is not a complications or not negligence. It is part and parcel of medical care. We'll try to help the patient and the family as far as possible. So this is very, very important. So if you have a staff like PRO, this really helps. You can train them and he can manage the situation. If not, we have to directly get involved, ensure that we take a professional help from the association. So for this is very, very important. We have to avoid professional jostling and talking ill about our colleagues. So this should be avoided. That's one of the reason local bonding is very important. And you have to set in certain process and protocol even for crisis management. We call it as code gray. Some other hospital will give a different code, but code gray is the general term for crisis management. So you have to learn from the mistakes also. What are the prevention measures? How to be prepared for this? So this has to be a continuous event. At least once a month, we have to discuss about this with our staff. So you need to stay connected, and need of the hour is because the incidents are raising. So we have to be working with our friends as professional colleagues, working with the association. We have to be active part of association, so that there is a crisis leadership that is really there to help you. So thank you so much for your kind attention. If any questions, we'll be happy to take. We expect your feedback and inputs as well. Thank you. So that completes the talks. We have some more time for discussion.